the invitation. I'm very happy to be here in this very nice Congress. The guidelines on the management of valvular heart disease, the version 2012, is really the product of a joint effort of the European Society of Cardiology and the European Association for Cardiothoracic Surgery. Members of both societies have been working together in the task force to prepare these guidelines. The previous guidelines on the management of valvular heart disease were published in 2007, so only 5 years before. So why did we need new guidelines for the management of valvular heart disease? And this is very simple because in these 5 years, new evidence has been accumulated on the risk stratification. For instance, the Euroscore, the STS score to evaluate patient for surgery was not used before. New diagnostic methods, for instance, three-dimensional echocardiography, magnetic resonance, CT scan, and so on, largely used in valve disease nowadays. And new therapeutic options also have been introduced in the clinical arena. For instance, the TAVI for aortic stenosis and the percutaneous edge-to-edge technique for mitral regurgitation. In addition to that, the heart team approach has emerged as a standard practice to evaluate patients with high-risk situations with valve disease. As you know, the heart team is a number of specialists getting together, sharing their knowledge to take decisions and to treat patients with valve disease. The heart team is particularly used in high-risk patients, but also for patients with asymptomatic disease, because, for instance, patients with asymptomatic mitral insufficiency, of course, we have to be sure that repair of the valve has to be guaranteed to the patient. Let me tell you something about the background, and particularly the burden of valve disease. With the aging of the population, the prevalence of heart disease is increasing, and particularly aortic stenosis and mitral regurgitation, and these valve pathologies have an important impact on survival of the patient. In the EuroHeart survey, you can notice that native valve disease was in 72% of the patient. The rest of the patient had a previous valvular intervention. Notice that about 20% of patients had multiple valve disease. When you consider single valvular heart disease, aortic stenosis and mitral regurgitation are by far the most common, and etiology is particularly degenerative etiology. Let's talk about patient evaluation. There are essential questions in evaluation of patients before valvular intervention. Is valvular heart disease severe? Of course, we have only to treat patients with severe valvular insufficiency. Does the patient have symptoms? Are symptoms related to valve disease? This is an important question because quite often comorbidities are present and maybe this can be the cause of symptoms. What are patients' life expectancy? This is very important also because, of course, we have to avoid futile interventions. Do the expected benefits of intervention outweigh its risk? What are the patient wishes? This is an area of personalized care. It's very important also to consider patient wishes. And of course, in the benefit of the patient, local resources have to be considered to offer the patient the best possible treatment available. Patient evaluation is based on clinical assessment and echocardiography. Echocardiography is certainly the key examination for patients with heart valve disease. By echo, we can check the severity, assess the mechanism, the anatomy of the valve, the lesion, and of course we have to be sure that the echo findings are consistent with the clinical assessment. These are echocardiographic criteria for definition of severe valve stenosis. You see here for aortic stenosis, mitral stenosis, tricuspid stenosis. It is very important not to rely on one single number, one single parameter. An effort should be made to have an integrative approach to judge about the severity of stenosis. The same when we evaluate patients with severe valvular regurgitation. We have here the criteria for aortic regurgitation, mitral regurgitation, tricuspid regurgitation. There are qualitative criteria, and of course semi-quantitative and quantitative criteria. Again, we don't have to rely on a single number, on a single parameter, but we have to consider the situation with a kind of integrative approach. There are other techniques to evaluate the patient: exercise testing, stress echocardiography, magnetic resonance, CT scan, and also cardiac catheterization, which is carried out nowadays only if no invasive findings are discordant with the clinical assessment. I don't want to spend time on the coronary artery management of coronary artery disease. Of course, coronary angiography is indicated in patients with more than 40 years or in postmenopausal women. And of course, if cardiovascular risk factors are present. An indication for myocardial revascularization, obviously, is when we have important coronary disease in addition to valvular disease. Let's come now to the individual valve pathology. Start with the aortic regurgitation. Surgery is indicated in symptomatic patients, and surgery also is indicated in patients with left ventricular dysfunction. If there is no dysfunction, if the patient is asymptomatic, surgery can be still indicated if the left ventricle is too dilated, for instance, left ventricular end diastolic diameter more than 70 and systolic diameter more than 50. Of course, patients with aortic regurgitation quite often have a dilatation of the ascending aorta. And surgery is indicated in Marfan syndrome when dilatation of the ascending, when the diameter of the ascending aorta is more than 50, and more than 55 in general for other situations. Of course, the threshold can be for intervention can be variable according to different situations in presence of Marfan syndrome, in presence of bicuspid aortic valve, if risk factors are present. For instance, if there's a family history of acute dissection, of acute aortic rupture, if there is hypertension, if there is some other rapid increase of the aortic diameter, if there's a desire of pregnancy and things like that, certainly deserve a special consideration, and also operation for a lower threshold of aortic dilatation. This is the management, this is an algorithm with the management of aortic regurgitation, and this reflects what I just said. In terms of aortic, in regard to the aortic stenosis, certainly aortic valve replacement is indicated in patients with severe aortic stenosis and symptoms. And of course, in case of CABG, even moderate aortic stenosis should be treated. Surgery is indicated also in low flow, low gradient, and normal ejection fraction. Surgery is indicated in low flow, low gradient, and very severe left ventricular dysfunction, particularly if flow reserve is present. If flow reserve is not present, then the indication is much weaker because the risk of surgery is extremely high. Surgery is indicated in aortic stenosis without symptoms in cases of left ventricular dysfunction, or when patients are symptomatic on exercise test. Of course, patients with asymptomatic aortic stenosis can be offered surgery when there's a calcification of the valve, when peak transvalvular velocity is more than 5.5 meters per second, and also when there is a progression in transvalvular velocity quite consistent over time. Surgery may be considered in presence of excessive left ventricular hypertrophy if there is an increase of mean pressure gradient with exercise more than 20 millimeters of mercury, and also in presence of elevated natriuretic peptide level. For the first time, the TAVI indication have been considered. And TAVI certainly is indicated when there is heart team set up, and also when cardiac surgery is on site. We had a lot of reaction to this because many centers think that this can be carried out also without cardiac surgery on site. So this is an ongoing debate, but we think that really that is very important to have cardiac surgery on site, and this has been a recommendation class 1. Surgery patients with inoperable aortic stenosis are candidate for TAVI, and certainly also patients with a high-risk surgery can be offered TAVI if the heart team believes that this is the best solution. Here you can see the contraindication for catheter aortic valve implantation. I don't go into the details. You can see here the absolute contraindication, the relative contraindication. I think this is an important piece of information that has to be followed with the present state of the art in this field. The management of severe aortic stenosis, the algorithm is presented here. You can see that for severe patients with a severe symptomatic aortic stenosis, TAVI can be considered when the patient is inoperable or high risk. Of course, it's important that the life expectancy is more than 1 year. Let's come to mitral regurgitation. The first recommendation is that mitral valve repair should be preferred when it is expected to be durable. If a good repair can be carried out, then mitral surgery can be recommended also in patients with a very severe left ventricular dysfunction, with an ejection fraction less than 30, left ventricular end systolic diameter more than 55. If we have to carry out replacement of the mitral valve, then indication for surgery under these circumstances is much weaker. Obviously, surgery is indicated in patients with mitral regurgitation who are asymptomatic, because the final goal is to have a neutralization of the disease. So also patients without symptoms, without arrhythmias, without left ventricular dysfunction, if they have also a dilatation of the ventricle, left ventricular end diastolic, and the systolic diameter more than 40 and the flail leaflets, if they have a large left atrium, pulmonary hypertension, exercise, certainly surgery can be considered, even in an asymptomatic patient. And here is the algorithm of the management of severe chronic primary mitral regurgitation. When left ventricular dysfunction is severe, surgery is not always indicated. Sometimes, particularly if the comorbidities are present, medical treatment can be offered to this patient. As far as secondary mitral regurgitation is concerned, surgery is almost invariably indicated when a concomitant coronary artery bypass grafting has to be carried out. In patients in whom CABG is not contemplated, the indication is much weaker because there's no evidence that the survival is better with surgery under these circumstances. And of course, for the first time, the guidelines are proposing the mitral clip procedure for patients who have severe symptoms, who are eligible, anatomically eligible for this kind of procedure, and if they have a life expectancy which is more than 1 year. Mitral stenosis, I don't want to spend much time on this because mitral stenosis didn't change very much the indication from the last guidelines. I like to point out now the contraindication for percutaneous mitral commissurotomy. When the mitral valve area is more than 1.5, if there's a left atrial thrombus, more than mild mitral regurgitation, severe calcification at the commissures, abscess or commissural fusion, severe concomitant lesion in other valves, and also if concomitant coronary artery disease is present requiring surgery. Indication for percutaneous mitral regurgitation are presented here. Patients have to be symptomatic with a favorable anatomy. if there's some contraindication to surgery, also this is a very good argument for percutaneous mitral commissurotomy. Even without symptoms, this type of procedures can be considered when there's a high thromboembolic risk. For instance, patients with a previous history of embolism, a dense spontaneous contrast in the left atrium, recent atrial fibrillation, paroxysmal atrial fibrillation, or when there's a high risk of hemodynamic decompensation, like when there's a desire for pregnancy or need for major non-cardiac surgery, pulmonary pressure more than 50. So you'll see these, the details are written here. I don't want to spend time on this, it's just reflecting what I just said. As far as tricuspid regurgitation is concerned, not very many changes, but only 2 changes actually. One, the threshold for intervention in on the tricuspid valve has been lowered. Patients needing surgery on the left side can be offered also tricuspid regurgitation correction if, even if regurgitation is only mild, provided that the mitral annulus is enlarged. In the apical transthoracic 4-chamber view, if we have an annulus which is more than 40 millimeter, then surgery is recommended on the tricuspid valve, even if the regurgitation is only mild. Another important change is that patients with primary tricuspid regurgitation can be offered, probably should be better off if treated even in absence of symptoms, if there is a right ventricular dilatation or initial right ventricular dysfunction. So a kind of more aggressive approach to patients with tricuspid regurgitation. I don't want to spend time on a valve prosthesis. I want to only to point out that nowadays the kind of discussion with the patient, this is in the vision of personalized medicine, of course, we have to inform the patient exactly on the precise problems of one prosthesis versus the other prosthesis, and we have to take into consideration the desire of the well-informed patient. I have to say that the threshold for mechanical valve has changed a little bit. A mechanical valve is preferably offered now to younger patients that used to be in the past. Bioprostheses are more frequently used, probably because there is a real improvement, a true improvement in the durability of the bioprosthesis nowadays, and also maybe in the vision of a valve intervention in the future. Indications for antithrombotic therapy after valve surgery. There's only one change compared with the previous guidelines, and this is that low-dose aspirin should be considered for the first 3 months after implantation of an aortic bioprosthesis. In the previous guidelines, oral anticoagulation was recommended. So only antiplatelet treatment can be preferred nowadays, and there's enough evidence for this statement. Of course, the oral anticoagulation has to be adjusted on the basis of a risk factor for thromboembolism. Prosthesis thrombogenicity has to be considered, as well as patient-related risk factors, and the target international normalized ratio has to change according to the individual characteristic of the patient. Prosthesis thrombogenicity has to be taken into account together with patient-related risk factors, and you can read here the different international normalized ratio target. Finally, I would like to present you a few situations like the management of left-side obstructive prosthetic thrombosis. This, of course, when you have a situation like that, you have to consider how critical is the patient. If the patient is very critically ill, then you have to go to surgery immediately. If the patient is not so ill, then you have to consider optimization of anticoagulation before. And then also for patients who have non-obstructive prostatic thrombosis, again, you have to consider if there is a thromboembolism, yes or no, and also the size of the thrombus. If there is a large thrombus and thromboembolism occurred already, then you have to go to surgery immediately or fibrinolysis. Otherwise, you have to optimize optimize the anticoagulation therapy. Finally, this is the management of patients with severe aortic stenosis and elective non-cardiac surgery. And for the first time, TAVI is appearing in patients who have severe aortic stenosis symptoms and have to undergo an elective non-cardiac surgery procedure. And TAVI can be contemplated in this case. I would like to finish with the loop of knowledge. You said knowledge is produced, is created by research and clinical trials. All this knowledge is incorporated in the guidelines, and we did our best to incorporate the current knowledge in the guidelines. And of course, education has to be based on the guidelines, and obviously we have to see the effect of all these on the clinical practice and especially on the outcome of the patient. Thank you for your attention.